On this episode of the ASC Podcast with John Goehle, we discuss the latest news, review recent survey experiences, discuss recent guidance on N95 masks, and in our focus segment, review the final 2021 CMS ASC Payment Rule, including the newest procedures added, and discuss changes in common ASC procedures.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. The ASC Podcast with John Goehle is brought to you through the generous support of our sponsors, Ambulatory Healthcare Strategies, Surgical Information Systems, Intalere, Encompass Healthcare Data Solutions, Medicus IT, and BHG Patient Lending. This podcast would not be possible without the support of our sponsors, all of whom have been carefully screened for the quality of their products and services and their dedication to the ASC industry. For more information about our sponsors, visit our website at ascpodcast.com and please consider them for your center's needs.
Happy holidays and welcome to episode 118 of the ASC Podcast with John Goehle for December 16th, 2020. We're recording from our studios in Spencerport, New York. This is Susan Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. Joining me is John Goehle, Chief Operating Officer and owner of AHS. He's recognized as one of the nation's leading experts in the ambulatory surgery industry. So I can't believe that Christmas is next week and all the other holidays that everyone celebrates. We're right in the middle of it all.
And this is going to be shocking to you, but I actually have most of my Christmas shopping done, and it's not even the 24th.
So do I. I even have a bunch of stuff wrapped and underneath the tree.
I saw that. The Christmas tree is very crowded this year.
Yes. But
most of them are labeled for two particular. So as we've mentioned over and over again, both Sue and I have become grandparents of little baby girls. And
and I have two grandsons, so they're usually the big recipients. But
but now
we've got a lot of stuff underneath the tree for Victoria. And John's been having fun shopping.
Yeah, I've actually, and I've held my granddaughter, Josie, twice now. So that's a big deal, especially with COVID, because I have to get tested every time I go and see her. But it's been an interesting year. I don't know about everybody else out there, but of course our Christmas plans are far different than normal. We're used to having big family get-togethers, and that's not going to happen. And but we're very happy that we're coming to the end of this year. We're going to really celebrate on the 31st. No way to avoid that. I think somebody said they just want to make sure that the 2020 really does end.
Yeah, they're not staying up to celebrate. They're staying up to make sure it leaves.
That's right.
Make sure we're done with it.
So as we're recording here on what date is
16th.
it? The 16th. Yep. The vaccine came out on Monday. Yeah. We watched it's funny, is the first time I've actually seen pictures of airplanes landing at airports and tractor trailer trucks moving that stuff out. And the first dose was given out to an employee of a hospital in New York City.
Critical care nurse, I think, right?
That's right.
So she's probably right in the thick of things.
Yeah, my daughter, I think, who works in a nursing home I think she's scheduled to get it tomorrow, if I remember right.
I think so. I knew sometime this week.
So we're very happy. But that does bring up, and we'll talk about that in a minute, because there are some ramifications of these vaccines, and I'll just kind of bring out my opinion about it. The final payment rule finally came out, and of course it came out at 7 o'clock in the evening, the night before we did the finance and accounting seminar, which was 2 weeks ago. So Unfortunately, that did not give us enough time to go through the payment rule to be able to give our listeners a very comprehensive view of what was in there. So we are going to hold another conference. I'll mention it again later, but at least mention it here. It's going to be on December 29th at 1 o'clock in the afternoon, Eastern Standard Time. And Christina Benton and I will go into probably spend about 2 hours talking about various things in there. So it'll be a little bit more comprehensive. But we are going to talk about it during the second segment here, which won't be anywhere near 2 hours, Sue. Don't worry about that. For those of you out there that don't know, Sue is a nurse, and even though she is slightly interested in finances, her head tends to hit the studio's table here.
And as I say, each time, it's a personal preference. I'm thinking of all the nurses out there that might really love finances and be interested in their, and they're probably cringing now.
That's right. Yeah. No, and indeed,
nurse or not, numbers haven't been my favorite thing.
Yeah, and there is a big need for nurses to learn this too. And that's one of the reasons that we both on the podcast and through the virtual conferences have been really working hard, to increase that knowledge base, because like it or not, you know this, unfortunately, is you're being as an industry, nurses are being dragged in kicking and screaming because, we get it. You want to do patient care. That's what you went to school for. But there are certainly things that you need to know in order to survive in today's environment.
Well, it's like math and chemistry. They were not, I loved, microbiology. I loved biology in school, but all nurses have to be very proficient in math because you're calculating dosages, and you're, in chemistry, you have to have the background. So, there's certain things that might be my favorite to learn about, but there's other things you just really need to know to do your job well.
You get this, but I used to joke when I was teaching in a nursing program, I taught in a master's program, and the nurses would come to me as I was showing these formulas, especially when I did some algebraic formulas for math, and they would say, oh, we're nurses, we don't understand it. And I said, well, I'm not going to use the correct word here, but I'll say baloney, because if you're giving me a shot,
and an IV, don't calculate that rate and that mixture if you're counting on your fingers.
That's exactly right. Yeah. I mean, and you do algebra in the process of doing that. It's just that I think just like when you put milliliters or whatever in front of me, I don't think much about it, but you put a dollar sign and I'm all set. I think it's the exact opposite with nurses. But again, not to all those. I mean, there are a lot of nurses really have become quite proficient in finance now. And of course, we just finished 2 incredible conferences, which the recordings are available. Just go to ASCPodcast.com. We just talked about the ASC Finance, Accounting, and Reimbursement conference or seminar. We're going to hold that twice a year, once in probably June of each year and once again in December of each year. So we just did finish the December one on the 3rd and 4th. Recordings available. It was a great 2-day conference. And probably the one that, Sue, you and I unexpectedly had fun doing, the credentialing conference.
Yep, and it just became so important all of a sudden. We just started seeing a lot of issues in our centers and different places, and we thought, well, what better way than to just get out there, do a full conference, because I think there's such a need, and somehow we just hadn't really realized as much before, but it was good. It was interesting. I think we could have, I think you were saying we could have spent probably 2 days a week. Well, we could have spent a lot more time even on it.
Yeah, and of course being the procrastinator that I am, I wrote you were there with me where I was writing the slides together. Sue does all my editing for me because I can't spell or anything with grammar. So Sue does all of that for me. And I was writing those slides the Sunday before the event on the Tuesday there.
Well, regulatory consultants and spelling, their eyes just glaze over.
But I'm writing these slides, and I think I was telling you, I just couldn't. I said, "How am I going to drag this on for an hour?"
Yeah,
and of course,
and it just kept coming.
It just kept coming, and then and I realized too that the audience that we had for the credentialing conference was or seminar. I got to get used to the seminar versus conference. Yeah. Conference is a big thing. A seminar is a shorter thing, but the audience was both, real credentialing coordinators and people that are really in the weeds doing the nitty gritty work, as well as the people that supervise them. So that's why we had to go into some more depth. For example, with the credentialing conference seminar, I talked a little bit more about what the regulations were, whereas most administrators would already know that. But we know that many credentialing coordinators are just kind of thrown into it without having the context. So I thought that went off very well. And we did have an episode, I think a couple episodes ago, where we did talk very briefly about credentialing. But if you want more depth, definitely go and look into that recorded conference, which was on which is available at ASCPodcast.com.
Yeah.
Let's talk about a few things that are going on in the industry. Fortunately, things are quieting. I don't know if I should say that. Quieting down really isn't. It's just that there's more depth to each of the stories that are out there, but fortunately there aren't a lot of new ones surfacing. So the Hospital Without Walls program is not going away. It has been extended. So the Hospital Without Walls program is a program that allows surgery centers to temporarily change themselves into a hospital. And the process is relatively simple to be able to apply for and become a hospital without walls. But as we've talked about on the podcast before, we don't generally, as regulatory consultants, or certainly on the podcast, really recommend this because of the complexities of what you've gotten yourself into. Suddenly, instead of having to worry about all of those conditions for coverage, which we all know and love for the surgery centers, now suddenly you're required to follow at least some of the rules with the conditions for participation, which is those rules that govern how a hospital runs.
And the whole billing situation is different as well, right? It
is. You actually use a different form completely for that. Now, we're not experts at all on it. As a matter of fact, none of our clients have switched over. For the concern, the other concern is what happens, how do you get back from it? And then, so there were some changes, which basically, the biggest change was originally when the Hospital Without Walls program was set up, the intention was that you would have 24/7 coverage. That's changed. Now they are allowing an exception for that. Yeah. But again, it's available. If you want more information, just Google Hospital Without Walls program. There's plenty of information up there, but I really wouldn't necessarily recommend it.
And I think a lot of centers are really as busy as they can be right now with the limited staffing that they have. And as long as the government continues to realize that the centers are already taking some of the burden off of the hospitals by just doing the procedures they're doing, then, I think that's kind of the way to go.
And we have heard that in a couple states, or at least one state we know of, and I won't mention it here because it could change by the time this episode goes out, but had shut down elective surgery again. And I know here in New York there was a threat at one point to shut it down, but they ended up shutting it down only for the hospital.
And I think that's what they had said. There was some misunderstanding, but
But we're hoping, and certainly there's a big push to avoid shutting down the surgery centers, simply because we learned a valuable lesson there. At least we hope everybody's learned a valuable lesson that there really is no such thing as elective surgery, shall we say. If you're going in for surgery, you might have elected the day to have it done, but not the actual need for it. Let's move on and talk about the vaccine. Again, we mentioned earlier that the vaccine rolled out on Monday as we record this. Very exciting news for everyone. On the Sunday before all of those deliveries we made, Sue, you and I were, it seems like 24/7 talking to our staff because we anticipated on Monday morning everybody would be asking about applying to get the vaccine. So
people have been.
Yeah. So here's my position on it. Unless you're one of those larger centers or unless you're associated with a hospital, I really don't recommend that you yourself, as an ASC, go out and acquire the vaccine and give them to your patient or to your employees, so certainly not to your patients. And the reason for that is that especially one of the two vaccines has a stability problem at different temperatures. So it has to be maintained at a very cold temperature until it starts deteriorating. So you have to be very careful about maintaining that, logging it. And I think there's also some legal risks that you take on that you really don't need to take on.
Well, I worry about, how are you sure that the staff that you're giving that to, how much of a health check do you have to do? Are there risks that you're not aware of? I believe at least some of them are the multi-dose vial, and they probably aren't stable for terribly long. So if you're ordering a few vials, are you going to be able to give it all in the time that's allotted with maybe a smaller staff? And we certainly don't want to be wasting any of it.
Yeah. And again, I guess we should state that both Sue, you and I tend to be risk adverse, and we as a podcast and we as regulatory consultants tend to be risk adverse. So, I mean, if you're willing to take on a little bit more risk than perhaps we are, then we understand it. But even
we're always just giving our opinion.
I think I do want to point out that my daughter, who works in the nursing home, they're not getting the vaccine themselves. They're contracting with a local pharmacy to get it. So I think that's probably your best bet is to try to strike some deal with somebody locally who and indicate to them that employees are essential workers and all. But
it seems so much more efficient too if some larger areas are giving giving out that vaccine instead of so many different small chunks of doses going out.
Right.
And then say somebody leaves your center or whatever, are they going to come back and get that second dose?
Yeah, that's
there's just
precisely right. Yeah.
Things that
we do need to point out too is that if you do, and this goes for the flu vaccine as well as the regular vaccine, if you do administer vaccines in your surgery center, let's go through a couple things that we should do. First of all, you have to have a vaccination program.
There's a policy that's on storage and handling.
It's a newer accreditation standard.
Yes. So you'd want to make sure you have that, regarding temperature, not keeping it on the door of the refrigerator, constantly monitoring the refrigerator temperature, that
and
kind of thing.
And what to do in case it does fall outside the range.
Yes, to call or when you have to dispose of it.
Yeah.
And again, a lot of times just bringing your pharmacy consultant in on any of these questions.
Right. And that's a good point, is that if you do decide to acquire the vaccine, you should bring your consultant involved into that process to assist you in there. So, and then in the December issue of Outpatient Surgery Magazine, they had a lot of great ideas. Do you want to mention a couple of them? And again, our friends over at outpatientsurgery.net is their address. So go ahead.
They always have a lot of good and a lot of really in-depth articles, but I just picked out some of the simple things. They have a section of ideas that work. Different centers tell what's worked for them. So there was an article on building a good, effective team, and they stressed giving team members the autonomy and the power to take an active leadership role, even in someplace you wouldn't think of necessarily as leadership. The sterile processing techs can be, deeply involved in ordering supplies because they know what they need and they know what might make their job easier. Nurses in the one center, they said their nurses rotate through the different areas to decrease their monotony. And just to allow for more flexibility and more understanding of each other's roles. And I love this point that they made. They said, although the final say always falls with the actual leadership, the leadership's job is to support the staff and not to have support staff for themselves. So just always remembering you're there to kind of build up your staff and let them become invested, and they'll do a much better job.
Yeah, and I just want to tag on to that because we know that we're having a very difficult time right now keeping our staff up for so many reasons. People are retiring because they're just done with the industry, or done with nursing and done with being a doctor in some cases. And then it's difficult to keep staff that are having to stay at home to support their young families now, through this difficult time when everybody is going to school. A lot of people are going to school virtually. So I think we have to find better ways. Actually, some of the board meetings, Sue, that you and I have been moderating, shall we say, a big topic of conversation is how do we recruit, how do we retain, how do we keep staff happy? We had an interesting conversation this week where somebody was talking about bonuses, and we all know that bonuses are not the only thing people are looking for. Money is not the only motivation. As a matter of fact, there are studies that show that that's not the primary motivation that people work in most cases. And it was an interesting thing because you and I were both saying too little money is actually insulting to the staff. And so there was this conversation, well, we don't have a lot of money this year. Let's just give them a $100 bonus. And given that their bonuses in the past had been significantly more, 10 times that amount, the administration just said to the board, if you're going to do that, don't bother at all. Because frankly, that's going to be like an insult. It's actually worse than giving them nothing at all. You could explain to them, if you're giving them nothing, that this has been a bad year. We'll make up for it later on when the finances get better, but
and find some other ways to reward them too.
That's right. And so I think you're right. And one just quick story. When I was running, actually both of the surgery centers that I was the administrator for over my career, we made it a policy that if you were going to be a full-time employee, because we had a lot of part-time and a lot of per diem employees. But if you wanted to move from per diem to part-time or part-time to full-time, you had to take on an additional responsibility in order to be in a full-time position. And so, for example, in the nursing side, that would be if you were a nurse, you would be the infection control coordinator. Or even if it wasn't the infection control coordinator, you could be providing support services for the infection control coordinator. You'd have an employee health nurse, for example. We would have one or more people involved in the quality improvement program, reviewing charts. We know how we have to do, chart reviews on a monthly basis. Educational program, that's probably a big one right there because, a couple nurses could be involved in that depending upon the size of your organization where they kind of run the monthly or weekly, whatever your policy is, staff meetings where you go through in-services.
Yeah. And I think the point of this, too, has to be not that you're trying to overload your staff, because at a time like this, everybody probably feels like they have so much to do, but letting them feel like they can have an effect on the overall running of the center. So, some very simple things sometimes can really change the mood in an organization. So one of the other things they had said is to put a do not enter sign on the OR door when you're in there. And staff knows, they can enter, but it's just kind of that red sign sort of stops them from just walking in and out and might make them think, can this wait till a little bit later, and wait till the procedure is done. Yeah. And then having monthly one-on-one meetings with staff if you can, or it could be quarterly. A lot of places will do huddles, which is important too. Yeah. But, sometimes just having that set-aside one-on-one time so they can air any issues that may have come up that they don't want to say in front of other people, or suggestions that they're just maybe not comfortable pointing out in front of everyone.
So I don't even want to do this next section. So why don't you at least introduce it while I just go scream in the corner?
Okay. So, and we've been talking about the N95s for a while. And I know a lot of centers don't even actually use them. They can't get them, or they can't get the fit test, or haven't had the fit test, or whatever.
Let's make it clear. You don't need to. You do not. There's no regulatory requirement for an N95. There are recommendations, very strong recommendations for the use of N95s.
And sometimes staff just really wants them. I probably would. But we've said this many times, but if you do choose to do that, you have to have a respiratory protection program, and you have to make sure they're all fitted. All of your staff that's going to wear one is fit tested with the particular mask that you have in your center, and that they know how to then check the seal when they put it on, all that kind of thing.
But one important point we should point out that is probably later on what you're saying, but let's just get to the one point very importantly, is that if you are wearing an N95 mask, you have to dispose of it after you take it off.
Yes, or it is contaminated, and I guess there's...
Or when it's contaminated.
We have to clarify, I guess, but, obviously if you get any type of liquids, fluid, body fluids, blood, whatever on there.
Which is, by the way, why N95s, because they're so expensive and because they're so in short supply, that's why generally people are not requiring its use. Yeah. But up until recently, what we have said, and again, we have said this ourselves as well as our recommendation, but we're going to talk about this, the new guidance here. We've said in the past, well, if you wear a mask over your N95, that would allow you to use in between procedures. However, Sue, go ahead.
There's some concern that that might affect the fit of the N95 because, you're wearing this other thing over, so it might compromise the security of that. So, because we have a couple things. There's a CDC take on extending the use of N95s, and then Lori spoke to someone at ARN and listened in on a respiratory protection webinar, and they're the ones that had said really you don't want to wear a face mask over, that they could recommend wearing a face shield over the N95.
And the reason for that, Sue, was, and this is a point that you've been making, but nobody's listened to you.
Yes, I know. I said, didn't I say that? But ARN has a little more clout than I do.
But go ahead. Well, again, your point being.
Yeah. So they're just, as I said, that they're concerned it may compromise that fit.
Yeah. Because it's pulling against the mask, which pushes that seal.
Yeah. They didn't explain exactly, but that's kind of my thought, was that if you're pushing, it might, then push it out to the side so maybe there's some air coming in there. Well,
and I don't wear an N95. I wear a KN95 regularly, which has somewhat of the same feel, not quite as well, and obviously not as
good.
But I can feel when I put another mask over it that it does misshape the mask.
Okay, so no more doing that.
Pardon?
No more doing that.
No more doing that.
Yeah. And the KN95s are not as expensive, so
that's right.
It's not as much of a deal.
It's easier to replace them.
Yes. So we actually think we're probably going to address this deeper in a future episode or talk more with Lori.
Oh, and Sue, by the way, Lori and I did talk about doing a 2-hour seminar shortly infection control.
Okay.
No, we
Thank
just
God.
need to kind of update everybody on the more recent guidance on it. So I'm sure this will be one thing we'll talk
One
about.
of
So
the
hopefully we'll
things,
schedule
yeah.
that in the next couple of weeks.
Okay.
This is live recording here. Sue learns things as we go along. Sorry, Sue.
Okay.
Surprise.
That sounds good. No, that's a great idea, though. And I'm just skimming through this. So what the CDC had basically said, extending through repeated close contact encounters with several different patients, but they are saying that this would be more of a hospital thing. Like if you're carrying with people with the same illnesses, like everybody has measles and you're going from one to the other, it's probably okay to wear them through. Anytime you remove the mask, as we've said in the past, it does have to be discarded. If there's any type of contamination, it feels like even from your saliva, it starts getting damp, has to be changed. And they did say just if it's contaminated with nasal secretions, blood, bodily fluids. But I guess we're not, but from a regulatory standpoint, it seems like you'd have to change them after every procedure.
I really feel very strongly about this. If you're in a surgical procedure or a dirty procedure, you don't want cross-contamination between one patient and another. Now, we get it, in the pre-op and the post-op area among staff that might be out in the waiting area. But when it comes to patients that are, that when you're in the room with the patient, when there's the possibility of very close contact, when you're manipulating the patient, that you really, whatever mask you have on, doesn't matter whether it's N95, a KN95, or a surgical mask, you need to replace that in between procedures. And that's based upon error and guidance, at its heart. So I haven't heard anything to say that that's different, but this is a very fluid situation, which is why, if you're comparing an episode 6 months ago to what we're talking about now, you would hear, actually, I think even 2 months ago, we talked about it. So please understand that this is why you need to listen to this podcast.
Well, and my favorite podcast doctor, Z-Dog, MD, he always says it, it's the science. We're following the science.
Right,
and that's the thing. We're not just flopping around on this, but as new things come out, we try to stay up on that. And a lot of this, as we've said all along, you've got to discuss it with your board. You've got to look into it yourselves and make some decisions about what you're going to do.
Let's talk about a couple recent experiences. We've been having a lot of surveys lately. The accrediting organizations are trying to get caught up as much as possible. And just a couple pointers. I can't believe I have to say this, but please don't argue with the surveyors. I had a recent situation where I was, we had a client and I just texted her over and over again. Please don't argue. Please don't argue. It just doesn't generally go over well with the average surveyor. And I'm speaking as a surveyor and saying that, because you're literally kind of, you're questioning their knowledge base. And
if you find a thing that if they've asked for something, you couldn't find it, if you then eventually find it, you can bring it to them before the end of the survey. But otherwise you deal with it afterwards.
Right. And you can always ask for clarification, but don't question that. So, and then we had another situation during the same survey where they were asking, it says, well, I don't understand what to do. What should I be doing? And the surveyor kind of came back and it actually kind of turned around because the surveyor got even more concerned that they had no clue as to what was going on. And the situation here is that the person that they were asking these questions from was not really, doing day-to-day stuff. So you have to be very careful about who you put in front of the surveyor there. So just a comment. And again, I'm talking largely about deemed status surveys. I will say during a regular accreditation survey, when I'm a surveyor on that, I'm much more likely to provide suggestions. Because I tend to have a little bit more time on a non-deemed status survey, and it's a little bit more consultative. But on a deemed status survey, remember, a surveyor is out there for two purposes. One is that they're doing an accreditation survey, but most importantly is that they're there on behalf of CMS to do a deemed status survey for your Medicare certification. So that's why they really are in a difficult position that they really can't be providing advice on what to do.
And they will offer it if they can. Most people are consultative if it's the right thing to do at the time.
Right.
But it's not really up to you to,
and don't
unless you need
waste
clarification on what they're looking for so that you can provide it to them.
And again, a comment that I'll make here, just because you passed last time with flying colors doesn't mean they're not going to find something this time. I'd say this over and over again, and I do need to emphasize it again. The job of a surveyor is tough. There are a lot of things you have to look at, and we can't look in depth at every single thing, every single survey, which means that we focus on things that we have identified as a problem, either through observation or through review of documents. But when we find an issue, that's when we tend to focus on it, which means that there are going to be things that perhaps in one survey weren't found in a previous survey.
Yeah.
Or so be prepared for that.
Or say it's your credentialing. They happen to get a good few files the last time and they didn't. So it's...
Yeah, and that's very true. It sometimes it depends upon what we pulled as randomly. And another thing that came up recently, it actually has been coming up quite a bit lately, is that with these deemed status surveys on the life safety side, remember, you need to maintain that documentation of the original construction of your place. In other words, all those original approvals forever. I mean, they need to be available for the surveyors every time. And I think in one particular case, our client was confused. They didn't understand why the surveyor was asking for information that they reviewed during a previous survey. And his point was, well, we have to look at it every time to make sure it's still available and that you have it here. So keep those in binders, keep them on the computer. I'm really recommending now that you use the computer as much as possible to save this
Easier
information.
to find stuff.
It is. And it's harder to lose it, and especially if you're backing up that computer on a regular basis.
Yeah, and if the only survey you've ever had was your opening survey, you have to realize that they're going to be looking at different things. They're going to expect you to prove that you've done what you said you would do. And the same actually with any subsequent surveys. They kind of hope for things to be looking better and better all the time. You're not supposed to just stay static and just at least maintain. But
okay, well, let's take a short break, and we'll come back and we'll talk about the CMS 2021 Final Payment Rule.
Is your ASC meeting all the infection control requirements in the new normal? Let the team of experts at Ambulatory Healthcare Strategies and the ASC Podcast with John Goehle help you be prepared for the new normal with a range of resources. Be prepared for the infection control challenges of your ASC. Our resources include our free podcast. We'll be adding content to help keep you apprised of the changes and the requirements for infection control. And of course, the podcast is always free.
And the ASC Podcast now has the industry's leading education program for infection control coordinators, which we refer to as the ASC Infection Control Coordinator Training 2020. And we'll be updating this every year, but this training is available at the ASCpodcast.com website. This is a recording of the training program to prepare nurses for the role as an infection control prevention coordinator, or to improve the skills of coordinators that already have that position in the ASC setting. And it was recorded on April 7, 2020. This is a full-day course focused both on the basic skills necessary to become an infection control coordinator and to build on skills that current coordinators already have. Particular emphasis is placed on the infection control challenges of our current environment and preparing for more rigorous surveys in the near future.
After completing the program, attendees will receive a certificate demonstrating that they received the training. The cost of the training is $199.99, and you can get more information about it at the ASCpodcast.com website.
Ambulatory Healthcare Strategy now offers ongoing retainer-based infection control oversight, which includes an annual infection control mock survey, or more frequently, if you wish, review and revisions to your infection control program annually and as needed, annual competencies for your staff on infection control, and that's done during the mock survey, annual training on infection control, also done during this survey, and that's designed for your staff, assistance in investigations of any infections that you might have, assistance in preparing your annual infection control risk assessment, and of course access to all of the AHS infection control resources that our clients have come to rely on.
And for more information on our retainers, visit the Ambulatory Healthcare Strategies website at ah-strategies.com or call John Goehle at 585-594-1167. Well, as we mentioned in our first segment, the final 2021 CMS ASC Payment Rule has finally come out. We were expecting it, I guess, November 1st. It didn't come out until December 2nd. So that was just a little behind.
Yeah, I think it's the longest it's been behind ever.
Yeah.
And just a little bit of history here, just to remind our listeners who are not familiar with this. Every year, the CMS comes out with what we call the HOPD/ASC Payment Rule. And again, the Hospital Outpatient Surgical Rule and the ASC Payment Rule are tied to each other, as I will demonstrate. And by the way, there's going to be a bunch of downloads that people can do if they go to our website. I'm going to make available of spreadsheets that I've prepared, because you know how much I like spreadsheets, as well as the entire payment rule and all of the attachments that came with it. So go to our website at ascpodcast.com for the show notes on this one. Can't guarantee that it'll be published the exact same day that the podcast is, but it will be up there shortly thereafter.
Yep, and you're going to have a special program on December 29th.
We are indeed. So Christina Benton and I, because the rule came out less than 12 hours, or about 12 hours.
Poor Christine.
Poor Christine, because she called me up that evening. I mean, I think we were both working on our slides, just not working on them, tweaking our slides.
At the last minute.
And she calls me up, and she was, I mean, she doesn't get teary-eyed like that, but she was a
little flustered.
She was a little flustered. Says, "What am I going to do? What am I going to do?" And I felt so bad for her, because her slides were a lot more dependent upon it than me. What we tend to do is she tends to cover like the payment rule stuff during the finance conference, and I tend to talk about the quality reporting. And as we'll talk about in a minute, there were no quality reporting changes. So I had like 2 minutes to talk, and she had 3 hours.
And she had a lot still to say about, there was still things that were consistent anyways.
But again, to remind everybody, so these rules come out in their draft form in July of each year, around July 1st, and that was running late, quite a bit late this year. It came out later in July. And then the final rule comes out after all the comment period on November 1st. And usually it's pretty darn close to November 1st. But this year it was more than a month late, for obvious reasons with everything going on. But so we're going to go over some of these things. If you want much more detail, definitely listen to the special program that we're going to have on December 29th. I don't know, Sue, that I came up with a title for it yet. But go to our website at ascpodcast.com, and there'll be more information about that as to how to sign up for it. So basically, here's what happened. The CMS updated the OPPS payment rates for hospitals that meet hospitals and surgery centers that meet certain applicable quality reporting requirements by 2.4%. So the update was based completely on the hospital market basket increase of 2.4%, and there was no adjustment this time for the multi-factor per activity. So this is using the same methodology that was adopted in the final 2019 rule. Again, one thing if you listened to our podcast last year, and I'm sure all of you have been listening for years, we noted that in 2019 they went from cost of living adjustment, a standard, like urban cost of living adjustment, to the hospital market basket cost of living adjustment. And the reason for that is the hospital market basket is a lot more in line with the true costs that cost structure of what happens in a surgery center, and certainly in healthcare in general. In other words, what they used to use COLA adjustment, or cost of living adjustment, that was the same as what you and I buy in groceries, which is very different than the costs that we incur in a surgery center. So, fortunately, they recognized that and fixed that problem in 2019. However, we do need to point out, even though they have this new process in place, it does sunset in 2023 unless it's acted upon. So it's kind of an experiment right now to see how well it works. Obviously, on behalf of surgery centers, it's worked very well, because the number is higher than what we would have gotten if we were using the urban cost of living adjustment. So CMS continued to apply the hospital market basket cost of living adjustment to the final rates. That's how we came up with the 2.4%. And those of you that have been following the podcast know that the projected in the proposed rule was 2.6%. So it's a little bit lower than what was originally projected in the preliminary rule. It should be noted that this rate applies to ambulatory surgery centers that have fulfilled the required ASC QR, or the ASC quality reporting requirements. So if you fail to report the quality reporting requirements, you are subject to a limitation on the amount of the cost of living adjustment.
Okay, and the final rule removed the inpatient only list. So CMS in the 2021 rule made the conclusion that the IPO list is not necessary to identify services that require inpatient care because of the changes in medical practice, including new technologies and innovations. So this isn't immediate, but CMS will phase out the IPO list over the next 3 years, and they'll begin by eliminating about 300 musculoskeletal-related services.
So this might be a good time for you and I to talk a little bit about a conversation we had before we recorded on the approved procedure list versus a covered procedure list. So there's been some terminology confusion. I mean, in the very early years of surgery centers, Medicare covered only a certain number of procedures, and there was a presumption that the only procedures that could be done in a surgery center would be those things that Medicare had approved. Over time, the terminology for Medicare covered procedures has turned to what we call the covered procedure list, or the CPL, and that is indeed the term that's used throughout the final regulations here, is that there is this list of covered procedures, which means that Medicare covers those procedures and has set a specific rate for them. Just because a procedure is not on the covered procedure list doesn't mean that you could potentially do it in a surgery center. But you brought up the case. Well, does that mean that we can do open heart surgery? Well, I guess,
and not that I think we can,
right?
But I've had this all started because I did have a client that wanted to know, well, where can I find out if this procedure can be done in a center? And
it was hard to answer that question.
I don't have a specific list to point to. And and again, sometimes it gets down to the terminology, and we have to make sure that we understand what the client is asking and what the center is asking. Is it going to be covered by Medicare? Well, that answer we can give them very simply by looking at the payment rule that comes out each year. Can you do that procedure in a surgery center? Well, I guess we can probably figure out that you can't do open heart surgery in a surgery center because you just wouldn't have the resources to be able to do that. But admittedly, it's getting tougher. I mean, let's face it, these total joints now. I saw I think I've mentioned this before. I saw a total hip replacement, which of course one of them is on the list this year. And I was just absolutely amazed to see it done in a surgery center. Given my mother had one many years ago and was in the hospital for, a week afterwards. So, so this is an evolving situation. So just to get our terminology correct, what we're referring to here is the covered procedure list of the CPL. Okay.
So again, the covered procedure list is a list of the procedures that Medicare covers and has assigned a rate to. Not always a great rate, but has assigned a rate to. And again, to put it in perspective, an approved procedure list, nowadays that term tends to be the list that we create internally in a surgery center that is allowed in our surgery center. So an approved procedure list or scope of services would be that list that you create in your organization, that you know that you have the ability to do those procedures, that you have the equipment to do those procedures. And that's, it's kind of off topic here, but make sure your approved procedure list actually has procedures on it that you have the equipment and the capability of doing. Yeah. I have surveyed
not just
centers.
Things that you'd like to eventually do. That's not
exactly. So again, kind of obvious, but sometimes there are certain things that we just don't look at on a regular basis, and that unfortunately that's one of those things that perhaps is you might make sure you do it on an annual basis. Take a look at it.
Okay, so what are some of the new procedures that have been added?
So 11 new procedures were added, and I can't say that I can pronounce half of these here, but I'll give you the CPTs. And again, CPT-4 codes are a registered trademark of the American Medical Association. All rights are reserved by them. So here are the HCPCS codes, or the CPT-4 codes for the new ones added. The first two rates are 0266T and 0268T. They're both implant procedures, very high reimbursement, $25,311.58. That is the national rate, by the way. You would have to adjust that for your regional factors. The hospital rate, interestingly, here is $29,444.52. This is one of those rates that the implant makes up a substantial portion of the reimbursement there. So that's why the two rates are relatively close. In most cases, you'll find that the HOPD rate is considerably higher than the surgery center rate. 0404T is a transcervical uterine fibroid ablation. That came in at $2,801.08 versus the hospital rate of $6,794.31. So keep in mind that the numbers or the percentage of the ASC rate versus the HOPD rate does vary depending upon the procedure, but they do tend to be quite a bit less. And then there's 21365, which is malar fixation, $2,399.13. Now, probably the most exciting thing that was added is 27130, which is a total hip arthroplasty. That came in at $8,833.04 versus the hospital rate of $12,314.76. So that is obviously a kind of a disappointing payment rate. And this is an argument we've been making all along, is that while we might want these things to be on the list, it isn't necessarily good news for us because it does set the lower end of the payment rate. And we know that most of the third-party insurance companies do tend to set their rates based upon the Medicare rate, hopefully as a percentage above it. 27412, autochondrocyte implant in the knee, came in at $2,944, 57282, which is a colpoplexy, and 57283, another colpoplexy, both came in at $2,801. And then one of the laparoscopy with a colpoplexy, 57425 came in at $3,813.40. And then there were two C codes, C9764 and C9766. C9764 came in, which is a lithotripsy code, came in at $2,167.40. And C9766, another lithotripsy, came in at $4,285.36. So it wasn't a huge expansion this year in the number of cases, but certainly, some good cases that were added to it. I did want to point out some of the percentage increases. Now, we talked about the overall rate increase, Sue, going up at 2.4% for the year, but we need to emphasize over and over again that just because that's the average rate, your mileage may differ. And as I'm looking at, I have about 25 codes that I pulled out and that I'll make available on the website here. And they range from a rate actually going down to the highest increase, which looked to be about 5.03%. So the one that went down is the 66821, which is the after cataract laser surgery, better known as a YAG procedure. That went down from $256.14 in 2020 to $255. Not a big decrease, only 21 cents. But I think that's just a general trend that we're going to see with that particular procedure, which really probably doesn't need to be done in a surgery center. So looking at some of the other more common procedures, 66984, which is our favorite cataract surgery, has actually increased 3.15%, went up to $1,044.65. So that's a little bit higher than the rate of inflation. So two of the G codes in the colorectal area in colonoscopy went up 4.4%. That's the G0105 and the G0121 went up to $403.11. So that was a pretty sizable increase. The one that went up the highest was rotator cuff surgery, arthroscopy, 29827. That went up 5.03% to $2,944.24. Other things like the regular colonoscopies went up about 3.8%. It's been a pretty good year actually for colon surgery. So that it's about time that they needed some. The cystoscopy went up 3.82. That's 52000. Carpal tunnel surgery, another common one, 64721. That went up only 1.52%. So that went up less than the averages out there. And again, some of those regular pain codes, some of the injections like 64483, 64490, 64493, they only went up about 1.81%. And again, by the way, the BLEF, I didn't catch this until now. BLEF went up 6.26%. So that is the highest increase. I kind of missed it up there. So I'm reading off a list that I'm going to make available to everybody so that they can see what the codes were. But overall, not a bad year. I did want to talk a little bit about the ASC quality, Medicare quality reporting requirements to tell you all the major changes that occurred this year. Sue, can you just start that conversation? I
can handle that.
You can handle it from here, so go ahead.
Yep. So there weren't any.
And isn't it a great relief that no changes to this? But it is important to note that since all of the quality reporting requirements in 2020 were put off because of the pandemic, we fully expect them to require that reporting to occur in 2021. So all those things you didn't do in 2020, you will have to do in 2021. And we'll probably we probably should have an episode where we talk about the quality reporting initiatives here. It's a little bit too much. We're already kind of running a little late here today. But again, no new initiatives and the quality reporting requirements for 2021. And that's a good thing. So we can kind of take a breather on that. But okay. Let's take a short break and we'll come back and talk about some of the things that are coming up in our world here.
You're never alone in the ASC industry. Many organizations are eager to provide an opportunity to keep up on all aspects of running an ASC, and in this section, we highlight the upcoming events.
Well, unfortunately, we don't have anything to really report. And it's not that you're not alone. It's just that everything is virtual now and it's hard to find it. So, again, we put our request out there for people to send us information if you'd like to have it included on our podcast, and we'd love to have that information. We do want to announce that the ASC Association's Winter Seminar is now a virtual conference. Of course, it's January 11th, 19th, and 25th. This is a very popular seminar, now a virtual event. It provides essential training for ASC billers and coders. So it's going to be during 3 afternoons in January, and you'll hear from industry experts as they discuss the coding and billing updates for 2021 and share strategies you can use to maximize your ASC's reimbursements. And again, don't forget about Christina Benton and myself will be presenting about a 2.5 hour session on December 29th. As we go to press here today, we don't have the information out yet, but if you visit us at ascpodcast.com, you'll see more information, and we'll have a new podcast before that event. You'll have to sign up for it beforehand. If you did attend the Finance and Accounting Seminar, it will be free, just so that you know. Don't forget about our Administrators Bootcamp. Prepare for the challenges of ASC administration by participating in the ASC Administrators Bootcamp. It is a program that has become so popular. We're already starting to plan another one in July. This one is almost filled as we speak to you on December 16th. So you better sign up very quickly. Hopefully we'll still have slots left by the time this episode drops. The bootcamp includes a lot of reading materials, virtual private consultations with moi, that would be me, and an intensive 4-day virtual conference presented in January 2020, which will be recorded. We already have a couple people that are going to miss like one day of it, so it's not a big issue. They can you can still see the whole thing. We're kind of laughing here because our puppy came into the studio and is licking me as I'm trying to read these notes here, and I'm trying to keep her away from the power cable, Sue. Sorry about that. So this is going to be a highly interactive program. I'm talking about the Administrators Bootcamp. Be presented to a limited cohort of students and will be done through virtual private meetings. And I just want to remind everyone to consider becoming a patron member of the podcast. It does help support our efforts here, keeps our equipment new, and we do need a new board, Sue. And, obviously there's a lot going on with the conferences, and there's a lot of new things that we're adding, including discounts. There is a $300 discount on the Administrators Bootcamp for members of that are patron members. So more information about becoming a patron member and all the benefits, go to ascpodcast.com. So that's it for this episode of the ASC Podcast with John Goehle. Join us again. And please, as I said, consider becoming a patron at our website at ascpodcast.com. And please spread the word about the podcast with your friends and your colleagues, and do us the honor of hitting the subscribe button. The sound editor for this episode, as it always is Susan Cronkite. Executive producer is moi, John Goehle. Research assistance is provided by my incredible team at Ambulatory Healthcare Strategies: Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Calritis, and Lori Rodricks. Music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute, legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. We would like to thank our sponsors, Ambulatory Healthcare Strategies, Surgical Information Systems, Encompass Healthcare Data Solutions, BHG Patient Lending, Medicus IT, and Intalere. For more information about our sponsors, visit our website at ascpodcast.com. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.